Welcome to Voices in the Work, a continuing education podcast from the Texas Opioid Training Initiative. I'm Dr. Lindsay Loetta, Associate Director of the Pharmacy Addictions Research and Medicine Program and Assistant Professor of Practice at the University of Texas at Austin College of Pharmacy. Voices in the Work is designed to share new ideas and fresh perspectives with health professionals and other members of the workforce about substance use disorder prevention, treatment, and recovery. The first season will highlight innovative training strategies used to teach future health professionals about substance use disorders as part of their health professions curricula. This continuing education activity is supported by the Texas Targeted Opioid Response, a public health initiative operated by the Texas Health and Human Services Commission through federal funding from the Substance Abuse and Mental Health Services Administration. Additional funding information is available with this podcast. The views expressed do not necessarily reflect the official policies of the Department of Health and Human Services, Texas Health and Human Services, or the University of Texas, nor does mention of trade names, commercial practices, or organizations imply endorsement by the U.S. or Texas government. As a reminder to listeners, all episodes offer continuing education credit. Information about continuing education credit is available in the podcast description. What happens when medical residents spend a week immersed in addiction medicine? Today, we're exploring an elective rotation that gives internal medicine residents the opportunity to learn from a range of professionals and community-based programs to see how substance use disorder care happens across different settings. Today, we are joined by Dr. Brooks Keener, a primary care physician with Community Care in Austin, Texas, where he provides addiction medicine care and leads addiction medicine training experiences for internal medicine residents. We're also joined by Daniel Sledge, the academic detailer for the Teach OUD initiative, where he works to expand access to evidence-based opioid use disorder treatment and education. Brooks, Daniel, so excited for this conversation. Thank you both so much for being here.
Thanks for having us.
Yeah, thanks for having us. This is awesome.
Yeah. Well, to start, for listeners who might have limited exposure to this area, how would you describe addiction medicine?
Yeah, for sure. So addiction medicine is basically just all the things that encompass taking care of people who are living with substance use disorders. And so some of that happens inside like traditional medical settings like hospitals. And for me, it's a lot of times in an outpatient clinic, providing evidence-based medications, but also connection with case managers and social workers, really just like wrap around interprofessional team-based kind of care, which is like really one of the most fun parts about it. And then it's also happens a lot outside of the traditional medical settings and out in the community, organizations, community advocacy type places, mutual support, peer coaching, all that kind of stuff is a big part of caring for people with substance use disorders. So, yeah.
I concur.
That was a perfect answer.
Yeah. That's pretty comprehensive.
Mm-hmm.
I think, and it's just, I wrote on my packet, it's like the part of healthcare or wellness that deals with any issue related to substance use. It's broad. And I think what's really neat about this, and we'll get into it later, but is it kind of takes it out of something that's like, oh, this is a niche specialty or something, and it says, no, this is in all aspects of medicine. So that we want everybody to be at least fluent in it, so that there's no wrong door whenever a patient seeks some sort of care.
And I'm glad you brought that up, because I think some people might have that, perception of, oh, this is a specialty or this is a niche area. Why is it important for all healthcare professionals to be trained or at least exposed to substance use disorders, regardless of any specialty they might go on to pursue?
Yeah. I think the reality is that people living with substance use disorders also seek medical care for all kinds of different chronic medical conditions. And their substance use disorder often impacts and is like deeply related to their other reasons for seeking healthcare. And so, there's really no specialty that is not going to be exposed to patients who are living with substance use disorders. And so kind of having that like shared model of what it looks like to care for those patients and I think like more simply like the patients living with substance use disorders are like deserving and should be treated with dignity and respect, just like any other patient. I think is such an important part of the training for medical students and residents and things like that, so that whenever they do go out and practice in whatever space they're in, they kind of like carry that model with them. And yeah, lots of times for even like the most siloed sub specialists, it's if a patient has a substance use disorder, they have to be kind of versed in what does it look like to provide those patients with care, because lots of times if they don't address their substance use, caring for their other medical conditions becomes really impossible, and so such a important part of that.
Yeah, and it's important because it touches all aspects of care. Like no matter what, branch or portion of healthcare that you work in, if you're treating humans, if you're not just strictly doing research, if you're treating humans, then you're treating people with substance use and substance use disorder, whether you know it or not. And that's the thing, and so a lot of, I might hear sometimes when I do clinical outreach, like, I don't want these people in my waiting room. And that's a jumping off point into several conversations, one of which is that they're already in your waiting room, and they might not feel comfortable disclosing substance use to you because there's a trust issue. And I think I think that exposing our early career physicians to and other healthcare providers to addiction medicine early in the career is so crucial, because there's a lot of bad habits that are out there that they might pick up on, like from more seasoned healthcare professionals. And so it's just a good, it's good to start that early, lay that foundation early, I think. Yeah. But again, it touches all aspects of medicine, healthcare, wellness.
Yeah, absolutely. Well, for our audience, think about your own training experience. How much formal education did you receive related to substance use disorder care, and where did that training occur? We're here to talk about a selective rotation, Brooks, that you created. So where did this idea come from, and like, how did you get started?
Yeah. Definitely wasn't something I did on my own. It was like a whole team, but it started actually back kind of as early as maybe 4 or 5 years ago, when I was kind of just getting started in my residency, and there were a few other senior residents ahead of me who had kind of put together a little bit of like a DIY experience with the folks at Community Care who were doing addiction medicine, and then also with some of the healthcare for the homeless team, kind of just getting some exposure to like vulnerable populations care. And so I kind of saw what they were doing, and I thought, that sounds really fun. Like I want to spend some of my elective time doing that. But it really wasn't like a formal curriculum at the time. It was sort of just connecting with the folks who were working in those spaces and trying to come spend some time with them. And so around that time when I completed that kind of elective experience, Dr. Embers and I got to talking about like, wouldn't it be really cool if we could create something that that, any resident could sign up for, or maybe that every resident could be exposed to. And that was kind of the beginnings of it. And then eventually I decided to stick around and do an extra year as one of the chief residents. And in the months leading up to that, I participated in a program called the Chief Resident Immersion Training in Addiction Medicine, which is a really awesome program that's kind of put on by folks at Boston University. But it was sort of like boot camp in how to teach residents about addiction medicine, like how to teach it. And so it was rising chief residents from all across the country who got to come and learn about like how could you work this into your kind of existing curriculum. And that was really where the actual sort of like nuts and bolts of the current rotation came from. And so the timing worked out kind of fortuitously as well, because the ACGME, which is like the accrediting body for all residency training, around that same time was kind of sending out revised recommendations that every internal medicine resident should have an addiction medicine experience as part of their 3 years of training. And so there was some definitely motivation on my end to like I said, kind of share something that I was excited about, but also some motivation from the program side. Like this is a gap in our curriculum that we need to fill, not only to meet this like accrediting requirement, but also to make sure that we're training, doctors that can go out and like be competent and and do a really good job taking care of people, no matter kind of what field they're in. So that's kind of where it got started. And so during my chief year, we did sort of like a pilot and just iterated and got feedback and had some really gracious residents who just jumped right in and like participated in those early kind of versions of it, and it's kind of grown from there, which has been awesome. But it's been a whole team. I feel like I'm leaving out people who have been so helpful in kind of the origins of this, and like people who laid those foundations even before I came along. So
That's so cool. And the program that you mentioned where you kind of got the nuts and bolts from, that's really cool that exists too. Do you know if that's still, I'm just thinking like if there's anyone listening who's like, ooh, I want to attend that. Like, do you know if they still put that on?
Absolutely. Yeah. So it's, like I said, a program put on by the folks up at Boston University. And actually, there were chief residents here at our program in Austin who had gone to this program before me. And that's like how I learned about it. And they were a big part of like, I think really laying the foundation for, like teaching addiction medicine in our program. And then there's been another chief who she's the current chief now who participated this year. So yeah, the program still going and like doing some really awesome training for rising chiefs and like kind of helping that get disseminated out all across the country, which is really cool. Definitely a lot of the design of the curriculum was inspired by kind of my experience there.
Very cool. Tell me, what does the typical week look like for a medical resident on this selective?
Yeah, so it has evolved a little bit, but basically, a big goal of the curriculum was to expose the residents to the real like interprofessional and like team-based elements of providing care to patients with substance use and substance use disorders. So a typical week looks like spending a few half days in the addiction medicine clinic at community care, working alongside folks like Dr. Embers, Dr. Lavasser, some of our advanced practice providers as well, Kristen Josephson and Matt Hunt. And then they spend a day in a methadone Curriculum Clinic in Austin with Dr. Casey Thomas, which is a pretty unique experience, a pretty different clinical setting than most residents are exposed to. But then outside of those kind of maybe more typical, days in the clinic type of experiences. They also get to work with some awesome social workers, both in the clinic and in the hospital. They're doing screening and brief intervention with patients. And they also go to an open mutual support group meeting to learn about what's going on in the community. And I think that's been a really impactful experience for the residents as well. They get to meet with Daniel, which has been for me, such an awesome gift to get to connect the residents with his expertise and experience. And
students and resident, everyone loves Daniel.
Oh my gosh, it is typically the highlight, the anchor of the whole rotation for the residents. And then kind of intermixed, there are some kind of half days during the schedule that are blocked off for them to do some more asynchronous type learning materials, modules and podcasts and some reading, stuff like that. So yeah, that's kind of what a typical week looks like. But yeah, really trying to expose them to that continuum of care a little bit as much as we can in just a 1 week rotation.
Yeah. And it's a 1 week rotation.
Yep. 5 days. It's pretty short. Internal medicine residents train for 3 years, and that feels like a long time. It is a long time, but really something that I learned definitely as a chief resident and kind of working towards building this curriculum was every week of those 3 years is really thoughtfully and intentionally designed to make sure that after 3 years they can go out and practice medicine in the community or go be really great fellows. And so time is tough, and we were really lucky to have awesome support from the program leadership and everything to actually set aside even just 1 week. But it is a lot to try to fit in. They certainly don't leave that 1 week experts by any means, but like we were kind of saying at the beginning, it's more about, I think, trying to have them just have that kind of fluency, that shared model for providing evidence-based and compassionate care to people who are really vulnerable and that they're gonna see no matter where they end up. So yeah.
I think it's cool too because they see all the aspects of care. So if they're working in the hospital and they're like, okay, when a patient comes in and I'm in the hospital, here's what interactions look like. But they get to see where people are coming from before they go to the hospital and where they're being sent and where they're having follow-up after the hospital. And I think they get a lot from the non-physician providers. So the case managers, the social workers, the peer support specialists and stuff. And the patients definitely, so they get to spend time with them and learn about aspects, social determinants and things that they might not have considered in a hospital, I got to hang out with the nurse at the dosing window at the methadone clinic and then talk to some of the patients afterwards. And they were telling me, kind of the routine of how difficult it is, or all the hoops they have to jump through to get to clinic, to get to dosing every day, and just things that they might not have considered. So I think it kind of zooms out and broadens you get to see where your puzzle pieces fit in the overall picture, I think, which is really cool. So then you're less like a lone wolf, and then you're like, hey, I'm part of something way bigger than me. I'm a part of this awesome comprehensive team, So yeah, I get to check in with them at the end of the week. It's so cool. It's like such a really neat opportunity, and just ask, how was the week and what stood out? Did you have any cases or interactions that just really stood out, or was there anything unexpected like that you were like, oh, this just really blew my mind, or my preconceived notions out of the water? And I hear there's a lot about social determinants and just things that they may not consider just working just in the hospital. And so I think just tying it all in is so, so beneficial, and knowing what all the other team members do, um, and just really taking advantage of, all the various roles of all the folks who are there for a common goal, you know.
Mhm.
So yeah, it's really, really cool.
Yeah.
Yeah.
I think I usually like ask the residents to write a very brief reflection at the end of the rotation, just like something they took away. And yeah, so often, I hope that they're like learning like how to prescribe medications and stuff like that. But lots of times it's such a unique experience. Something they haven't experienced before is just like seeing a whole team of people that is really providing such compassionate like care for patients with substance use disorders, like we were talking about earlier. So unfortunately, like so often, their experience has been like seeing how stigma like affects the care of these patients in the hospital, or in other settings. And so to just get to like be in a place where it's like a whole team of people just loving on patients who are struggling is like, I think, a real I don't know, a different experience than a lot of them have had before. And so lots of times that is the big takeaway, is like just seeing that the care of these patients in sort of a different light, which is cool.
Yeah. And like, I'm thinking, Daniel, like when you mentioned how sometimes learners pick up habits that we wouldn't want them to pick up from, as you said, like maybe someone more seasoned or like who didn't have that education. Like, this is so cool. It sounds like you're making the most of the 5 days, getting, as we said, like comprehensive exposure to so many different people. Sounds like such an impactful experience that they'd carry into their future practice and hopefully model the, actions that they saw from all the people that they got exposed to on this rotation.
I hope so.
Yeah.
Yeah.
Daniel, tell us, I know you talked like a little bit about it, that you close out the week, but tell us a little bit more about your contribution as part of this elective.
Well, before they talk with me on the Friday, so kind of to wrap up the week, they'll have watched the Teach OUD video, the CE video, and there's multiple speakers and teachers on that who talk about the medications for opioid use disorder. I think one of the most powerful things, though, in that video is that there are 7 people with lived and living experience and expertise, and giving their insights, not just about the medications per se, but about their interactions with healthcare providers, and talking about the impact of a negative interaction, and how that can dissuade somebody from re-engaging in care for anything, not just for substance use, but for anything at all, whether it's infection or something like that. But when we go over things, I get to just kind of say, what questions do you have, or what stood out, or do you want to review a case or anything? And I'll get the whole gamut, like we were talking about the other day. There might be somebody who had questions about, like, well, how are these different drugs used, or how are these different pipes or paraphernalia used? And that's awesome. I can answer. That's somewhere where I can utilize my lived experience. And then there's all the way to like super academic stuff, like I don't know. One was about ketamine resetting the sensitivity of mu opioid receptors, and I was like, yeah, I don't know. let's take a look though. I think that's important too, just about teaching in general, is don't be afraid to say, I don't know. And then let's go find out, So we looked it up. And it was really cool. So in that instance, I was learning from that particular resident. But and I think there's sometimes pressure, like we got to know everything and know how to fix everything and stuff. But some of the academic detailing people that I follow say you don't have to be the library, just the librarian. So like, let's go find out where to find that information. Let's walk you over to the stats and find it out. So. But all kinds of questions, and there's always comments on like, man, I wish we got this a little bit earlier so I could utilize this, so I could already have been putting some of this into practice and have these insights. I wish my entire cohort got this, like back when it was just an elective. What are some other things? There's one that I won't forget, which is they were shadowing Dr. Embers in clinic. And what stood out to them the most was that every time they went in to see a patient, they just listened to them. And they commented like, we listened to like way longer than what they're used to, before a patient gets interrupted by the provider. So we just listened to them and they're venting and all this stuff. And the first thing that Dr. Embers would say is like, I'm really glad you're here, and that just like really, really stood out to this resident. And they're like, I just thought that was so cool and so powerful. And the patients could feel it too, because it's genuine, So, I think it's just a good wrap up of just all the things that they were. And then knowing too, like, it doesn't end after this week, this is just kind of a jumping off point.
Yeah.
And knowing that, like, no matter where you go in medicine, where inpatient, outpatient, whatever the specialty may be, that these substance use is going to touch every aspect of the care that you provide. And so just having that confidence, and you don't have to be the most like, the cutting edge researcher expert on addiction med, but just having that fluency and whenever it comes in or you see it and saying like, I know how to speak this language and, I'm confident in caring for this in an evidence-based and compassionate way.
I love all those examples that you just shared.
Yeah.
Take a moment to pause. What types of experiences do you think are most likely to influence a learner's understanding of substance use disorder care? Didactic instruction, clinical exposure, interaction with multidisciplinary teams, learning directly from people with lived experience, or maybe a combination of multiple of these?
I know for me, it's like getting to work with Daniel and like to have him meet with the residents at the end. It feels like a cheat code, because Daniel can share such a range of your experience. Like some residents come in and they want more of that like academic detailing, like they want to learn like how do I start buprenorphine really, when I and they have a lot of questions about that. But other times they have all kinds of other questions, and I feel like Daniel brings such a unique experience and dynamic and that like probably would have taken like 5 or 6 people to, usually to meet with the residents.
You guys.
No, it's awesome, and like that the feedback I get a lot is like that kind of wrap up is such a like a key part of it. And then like you mentioned, the main feedback I've gotten so far from the residents is like wanting this earlier on in their training. Right now, we're mostly, all of the residents that are assigned to the selective are in their 3rd years, like in their last year of training. And mostly that was just like a logistical decision more than anything. Like that was the time in the curriculum that we were able to like carve out that 1 week. But definitely that's sort of like a future aspiration is like, how can we expose first-year residents and second-year residents to addiction medicine earlier on?
Another thing that's cool is in terms of like sustaining programs like this is it's a good place to sort of identify future champions, and really foster and nurture them. It's like you're you're identifying your future collaborators and partners and predecessors, because that's the key to making a program sustainable. Is that like, if Brooks and Dan here take a 6 week vacation or something, like, you don't want the thing to like, oh no, we can't, like,
Yeah.
you want to become obsolete. You want a program to be able to continue that momentum, that forward momentum, with or without you, so that it's scalable and sustainable. And then you're identifying those, and you're inspiring and empowering those future champions, and somebody who comes forward and says like, this is I want to do more of this, and it's like, welcome to the family, to the island of misfit toys, and like, you're home now. And then let's set you up, and then in a matter of months they're teaching other residents about it. It's really cool.
Yeah. It's very empowering.
It is. Yeah.
So if a educator or residency program director, or even a resident, like you said, because that's when you got exposed, if someone's listening and they're thinking like, I wish I could bring some element of this to, the training that they offer or that they're participating in, what would be your advice? Like, champions, I love that idea. What else?
Yeah, I mean, I think that's a huge part of it, is identifying the other people in your program that are they're also excited about it. It's doing any kind of project or any kind of curricular development is not something you can do on your own, I don't think. And it's definitely, like how do you identify the people in leadership, the other kind of clinicians who are excited about it and who are going to eventually hopefully help you teach trainees. And then I think a big element for me was partnering kind of early on with our program administrators. Like every residency program or training program that is doing good work, like at the core are some like really hardworking program administrators that like make the rubber meet the road. And for me, that was like a crucial part earlier on, is partnering with them, kind of trying to figure out more of that like scheduling and logistics type element of it that is often, I think, the barrier to this kind of thing. Usually like finding people that are excited and passionate is not that hard, but it's about how do we like really bring this to reality and like actually like get it going. And I think partnering with those administrators is really key. And then, I mean, I think I was very fortunate to have, we were fortunate to have great support and buy-in from our program leadership, like right at the beginning. But I think that's a big part of it too, is kind of making that case for carving out this like really precious time. And so I think working closely with like program leadership is really important. Yeah.
And I think also heavily involving people with lived and living experience and expertise at every step of the way. And like we were talking about earlier, some of the most impactful, stories or memories or experiences that the residents talk about is like, man, I was talking with some of the peer support specialists that work at the clinic, and they were telling me this and that, or they were sharing these things that I had no idea of, or I was talking with patients at the OTP at the methadone clinic, and I just never even considered like these logistical challenges or things like that, and just putting the big picture together. You can't do that without the insights and the expertise of people directly impacted.
All really great advice. What about sustaining a program over time? What thoughts do you all have there?
Yeah, I think I think we're still kind of in the beginnings of this, at least, in our program, this selective rotation experience. And, but definitely it's about kind of like building the team around it. And so I think the first few iterations, like residents that came through last year, it was definitely me just kind of like sending a lot of emails and kind of just I don't know, trying to keep make it happen at the beginning so we could try it out. But since then, it's become more sustainable, I think, because I've been able to like find these other people who can like kind of share in the work. And that's, I think, what's hopefully going to help it last. Yeah. Like long after I'm gone. And identifying also, like Daniel was saying earlier, those residents who are coming through and are like really excited about this and who can like continue to carry and to teach other residents. And sustainability is not easy though. Like I think that's something I've been thinking about more recently is like how do we make sure this becomes like a part of the curriculum for as long as it's needed. I think we still have work to do there, but definitely like just bringing on as many people as you can. I think is a big part of it.
Partnerships is everything. And then I think going forward is maybe showing the value of programs like this to kind of the admin or the higher ups or the brass, saying like, hey, this is impactful and valuable. And that probably gets into more like scalability, but yeah.
Well, Brooks, Daniel, thank you so much for telling the story behind this selective. I hope listeners take a lot away, and maybe we'll see some residency electives come out of this. But thank you both so much for sharing your story.
Yeah, thanks for having us.
Thanks for having
really
us.
Fun.
Yeah. Well, as we wrap up, consider your own educational setting. What opportunities exist to strengthen SUD training through partnerships with community organizations, multidisciplinary teams, or people with lived experience?